Twin birth is not something to be feared. Like all birth, it's to be respected because the things can go awry and you need to be vigilant. But when they don't, and when you make it to term with twins without any real significant problems, and we'll talk about the fake problems that you'll hear about from your maternal fetal medicine specialist, but if you make it to term, then it's just a vaginal delivery followed by quickly by another vaginal delivery. Right.
Hello and welcome back to another episode of the Birth Lounge podcast. Happy November, you guys. I know it may feel a little bit early, but I wanted to go ahead and give you a heads up about our Black Friday sale because this is one of only 2 sales that we do every single year. And I want to be super transparent with you. I don't run sales on the Birth Lounge except for Mother's Day and Black Friday because, to be completely honest, the Birth Lounge is priced fairly. So there's very little room that I have to run a sale and still be able to have a business, to be completely honest. I don't actually inflate my prices because I want this information to be accessible to everybody year round. And so that's why I don't have a lot of sales. We literally run a sale on Mother's Day to say thank you to you guys, and then again on Black Friday for anybody who missed the Mother's Day sale or has gotten pregnant between Mother's Day and now the end of the year. So I give you 2 chances to get into the Birth Lounge at a little bit of a reduced price, but other than that, there are no sales. Now, let me tell you about the Birth Lounge because it is literally unhinged. It is like nothing else you're going to find out there on the market. And that is the way that we are able to have the results that we have. We have people that literally walk away with absolutely zero birth trauma and they achieve all of their birth goals and they have no tearing. They push for less than 30 minutes. And the best one yet is that we have just a 3% C-section rate. Yeah, I am able to help you truly go into the hospital system, navigate the conversations with your provider, stay in control from start to finish, and avoid unwanted interventions and unnecessary things like an unnecessary C-section or an unnecessary induction. So how can this be? Well, I'm teaching you the control method, which is going to help you understand all of the aspects of labor that are within your control. And then we're going to teach you how do you control them. The problem that I find with a lot of traditional childbirth ed classes is that they just teach you your options. They say, well, you can have this or you can have that, and these are what your options are. But then when you get in the hospital system, you find that you're getting pushback from staff, or you are feeling like you don't really have those options, or maybe you're feeling pressured and you don't know how to navigate those conversations. That's exactly what I teach you how to do. I'm deconstructing all of those barriers, those road bumps, those things that hold you up from actually achieving your goals, because just knowing your options is not enough. The Birth Lounge is a comprehensive course. So when you go with the Birth Lounge, you will not need any other form of preparation when it comes to preparing for your birth. Inside the Birth Lounge, you are going to learn stages of labor, the ins and outs of navigating the hospital system, how to engage in respectful collaborative conversation with your medical team, pain relief options, labor positions, pushing positions, how to reduce tearing, How do you avoid things like induction, C-section, and unnecessary interventions? And finally, how do you advocate for your goals so that you can say yes to the things that matter to you? You can request alternatives when that's appropriate, and you can decline things that don't feel good to you. Plus, in the lifetime membership, you're going to get free access to our Dad Days course, which is a comprehensive course made for male partners to help them understand how can they best support you in pregnancy? What is their role in labor and delivery? How do they advocate for you? How can they keep you comfortable and provide pain relief during the birth experience? And then finally, what is their role in postpartum, and how do they help you navigate this new space of becoming a mom in the best way possible? You're also going to get access for free for our secret sauce to pushing. This is where I teach you how to achieve those results I talked about in the beginning, pushing for less than 30 minutes, avoiding tearing, and really understanding what muscles to engage to properly push your baby out. First of all, your pelvic floor does not push your baby out. That lady needs to yield out of the way. So what muscles do you use? That's exactly what I'm teaching you in the secret sauce to pushing. And yes, I'm teaching you how to push with an epidural and without an epidural. Don't worry, I don't really care how you birth your baby. I want you to be equipped no matter what pops up in your labor, because this is your birth. I want you to choose how you want to do it. My job is to make sure that no matter what choice you make, you feel empowered in doing that. You're also going to get one of my number one downloads, which is our scripts for advocacy. This is an entire packet of the most common conversations that you're going to face in labor and in the end of pregnancy that often start you down this slippery slope of handing over your control. Not only do I provide you with the evidence to have these conversations, but I'm actually giving you the words to have these conversations, i.e. the scripts for advocacy. In addition to that, you're going to get all of my PDF guides, partner guides, epidural guides, induction cheat sheets, and my brand new Birthing Your Big Ass Baby course, where I step you through the actual data of truly evaluating whether your baby is going to be quote unquote big or not. What does ACOG say? What does the AAP say? And what are the true medical recommendations when it comes to suspected macrosomia, i.e. a big baby? I think you might be surprised to learn that less than 1% of all babies in the US are born truly meeting the criteria for macrosomia. So why are inductions and C-sections so common? Well, that's exactly what I'm teaching you in the Birthing Your Big Ass Baby course, and I'm going to teach you how you can decline those if they don't feel aligned to you. And finally, probably my favorite perk of the lifetime membership is you get a box that is handpicked by me, curated to help you have your best birth possible. This is a birth box that includes all of my favorite things, not only that I have used for the last 10 years to help women achieve their best births, but the same tools that I'm using in my own birth. Things like a TENS unit, a rebozo, a comb for pain relief, self-care items, breastfeeding items, and so much more. One of my favorite things is actually the fuzzy socks. I love them. They're so soft. Oh my gosh. This box is packed with goodies. It's worth over $120, and I'm sending it to you because I want you to be equipped to have the absolute most glorious and joyous birth experience that you possibly can. And I know that you can't do that without having the proper tools. And so not only do I teach you how to use those in the birth lounge, but I'm gifting them to you because I want them to be part of your birth bag. So for 5 days only, on November 24th through the 28th, you will be able to take advantage of our lifetime membership and $150 off. You can visit thebirthlounge.com/join to take advantage of this special Black Friday deal. Again, 5 days only, November 24th through the 28th using code BF25 at thebirthlounge.com/join. Again, that code is BF25, 5 days only, thebirthlounge.com/join. Do not miss out on this. If you miss this sale, you'll have to wait till Mother's Day. I genuinely cannot wait to help you have your best birth possible. I'll see you in the lounge. Bye. Ooh, you guys, I have such a good episode for you today, and I'm so stoked for our guest today, Dr. Stu Fischbein. I'm sure so many of you are already aware of who he is, and this episode is extra special because you guys have requested this topic over and over and over again. There's so much misinformation out there about twins. There's so much fear out there in the medical system about twins as well. Should you be induced? Do you even have a chance to wait for spontaneous labor? Is it safe to go past 35, 36, 37 weeks? Can you have a vaginal delivery? Is C-section really safer? And the real problem is, it's nearly impossible to find the correct data. So of course, I tracked down Dr. Stu, who is a friend and a mentor of mine, and I asked him to come on the show to have a transparent conversation. I wanted to break down things like how many twins are born each year and how many of those are born vaginally versus cesarean. What does ACOG really suggest as far as the quote-unquote best method of delivery for twins? And what's the research say about outcomes for planned vaginal twin births versus planned C-section? Dr. Stu Fischbein is a community-based obstetrician and an associate of the American College of Obstetrics and Gynecology. He has peer-reviewed papers about home birth and is the author of a book, Fearless Pregnancy: Wisdom and Reassurance from a Doctor, a Midwife, and a Mom. And in 2018, he published a research article, Breech Birth at Home: The Outcomes of 60 breech and 109 cephalic planned home births and birth center births, so that we could really take a deeper dive into the safety of breech birth. After completing his residency at Cedars-Sinai Medical Center in LA, Dr. Stu spent 24 years assisting women in hospital birth, and then he spent the last 13 years as a home birth obstetrician who worked directly with midwives. Since retiring from attending home births in 2022, Dr. Stu has returned to his focus of traveling around the world as a lecturer and advocate for reteaching breech and twin birth skills, respecting the normalcy of birth, and honoring informed consent. And if you didn't know, he also hosts his own podcast called the Birthing Instincts Podcast with his lovely co-host, Bliss Young, who has also been on the show in episode 232, where we discuss, is home birth right for you? Today's episode is going to tackle some of the toughest questions and some of the questions that you might not even be able to find the answers to within mainstream medicine, like questions about ECV or external cephalic version. And what about extraction? What about if your provider says, yes, they're trained in breech and twin birth, but they only offer extraction, but you're not comfortable with that? How do we navigate that conversation? If you've never heard of interlocking twins, we're going to talk about that as well. Plus, we're going to talk about the number of twins that actually involve a breech baby. And then finally, we're going to tackle the question about, are there certain twins that can be born vaginally versus types of twins that really should be born via C-section? And of course, and I know you expect nothing less, us two home birth advocates would never get together without discussing the topics of whether twins are truly safe to be born at home or not. Now, let me give you a little forewarning. This episode is likely to challenge thoughts that you may have held for a long time. It might even bring up some questionable feelings of, oof, that makes me feel big things. I want to invite you to lean into that. This is how we start to challenge a narrative that is doing women harm within the system. This is how we start to change the narrative from you have to do this because this is the way we've always done it to a conversation of informed consent and truly exploring all of your options. It is truly one of my deepest honors to have Dr. Fischbein on the show. So, without further ado, Dr. Stu, welcome to the show.
Thank you, and congratulations on your upcoming blessed event.
Oh,
It's
thank
fun.
you so much.
It's so fun following you on your page to see how you're growing. So it's very exciting, and and just to see you and your partner just beaming is great.
Thank you so much. Well, I am thankful for you for being here. And I got to tell you, you are someone who's made such an impact on my own practice as a doula. And every time we hang out, I love being around you and I love hearing about what you've got going on. And I'm proud that you are representing the birth community and all the spaces that you are. And we can talk about all that at the end. But today, I'm really excited to dive into a conversation that I think a lot of people want, but they're kind of gaslit and railroaded by the hospital system because in the US, we have a very specific way of treating twins, even though most women intuitively know. Wait a minute, I can have these twins vaginally. So I think a really good place for us to start out is to kind of paint a picture of what the current landscape is. How many twins are we having each year? And then how are we seeing these twins born? C-section versus vaginally.
Well, twin rate has changed a lot in my lifetime. I mean, when I was a young resident, the rate of twinning was about 1 in 80 pregnancies. Now it's about 1 in 32.
Wow.
So it's about 3% of all pregnancies are twins now, mostly due to assisted reproductive technology. So, you could add that up, you could do the math. There's a little under about 3.8 million babies born in the United States every year. 3% of that is, I don't know, a lot.
Yeah.
Yeah, I think it's like 90,000 or 100,000 sets of twins or more. I think I might be okay. That's about right, I think. The problem is, of course, is that most twins in this country are born by cesarean section, despite the literature stating that that is actually not indicated for most twins. And we'll get into that, I'm sure. So about 75% are born by cesarean section. And unfortunately, of the 25% that are allowed to labor, about 20% of those moms, after they deliver baby A, will have a C-section for baby B,
Oh, that's
which for
horrible.
those of us that are skilled in twinning and breech extraction and internal pedalic version, it's extremely rare for that to be necessary. And yet it happens all the time because most of my colleagues are very uncomfortable with breech. And over half of all twins will have at least one baby be breech. So it's about 53%. In our paper that Rix and I just put out last December, our twin rate was 44.7%, which was a little under, I mean, excuse me, our breech rate, I'm going to screw up those words
That's
constantly
okay.
today, was just under the average, but it's about 50% of twins. And I'll reiterate this probably at the end of our conversation too, but obstetricians are supposed to be experts in all things pregnancy. If 3 to 4% of singletons at term are breech, and 3% of twins are 3% of pregnancies are twins, and half of those have a breech baby, you're talking about 4 to 5 to 6% of all pregnancies at term having a breech baby involved, and they're not taught how to deal with that anymore, other than with cesarean section. And I think the fault lies with the training programs and also the lack of intellectual curiosity, the lack of desire on the part of my colleagues to learn the skill, and also the fact that the system is designed for them not to have individual choice. So they may want to do a breech delivery, but their system doesn't allow it, their hospital or their employer. And again, since most doctors these days are not independent anymore, they used to be, we all used to be in private practice and the patients belonged to us and we would bring them to the hospital. And then the hospital figured out that that wasn't a really good business model, and they decided that they wanted to get the patients' lives themselves. So they started to take over. That's where HMOs and managed care and all that came in. And that was in the late 80s. And then the doctors became employees. And when you're an employee, your fiduciary duty, your ethics are conflicted because you're supposed to be responsible to the woman that you're taking care of, and yet your salary is paid by somebody who may tell you not to do certain things, like we don't allow VBAC, or we don't want women going past 41 weeks, and we certainly don't do breaches vaginally. Even though you know that the literature supports that, and the ultimate decision of how to proceed with a breech baby depends on some safe criteria, but it's ultimately the woman's decision. And if you don't honor that, then you're doing something that I'm trying to be gentle here, but is unethical.
Yeah, there's no need to be gentle here. I mean, hey, we're not in this business to be gentle with a system that is traditionally oppressing and taking advantage of women, right? Like we're in this business to better births and to make sure that we can reduce trauma for women and to make sure that we are actually improving outcomes. And we know that if 90 to 100,000 births of twins each year are being forced into C-sections when really we don't need that. And the true answer is to teach these doctors the skills that they lack. I don't see that there's any reason for us to be gentle about that. So I do have a question about medical school. Do you think that the curriculum that people are learning is literally just anti-vaginal breech birth, anti-vaginal twin birth, and simply to say give them a cesarean and these doctors know no different?
Yeah, I do. I think it's mostly residency. Medical school, they don't really get into the details of that. You learn more about anatomy, and you do rotations and things like that. So you spend 6 weeks on an OB rotation, and you're going to see nobody doing a vaginal breech or a vaginal twin delivery. So that's your exposure in medical school. When you go into residency, they just don't teach it anymore. The people that run the programs, generally they're maternal fetal medicine specialists, which are supposed to be high risk specialists, but they don't teach it anymore. And the reason they don't teach it anymore is complex. People will argue that there was a paper that came out that codified the idea that it's safer to deliver breech babies by cesarean than by vaginal delivery. However, there were numerous papers of better quality that said the opposite. So they cherry pick their data, which is very typical of people who work in any field. They'll have confirmation bias. And so one of it is that. The other one is economics. It's hospital systems make more money when a woman has a cesarean. There's no doubt about that. Some of it's expediency. It's easier to do a C-section at 7:30 in the morning on a Tuesday and be out by 8:40 than it is to be in labor with a breech or a twin pregnancy, where the hospital may even have a policy that says, well, Dr. Fischbein, if you're going to let this lady deliver vaginally, you're going to have to be in the house the whole time. House is what we used to, that's what we call, yeah, hospitals. You have to be in the hospital, which means you can't be at home for dinner. You can't be in your office seeing your other patients. So so if I get paid the same to be there for 45 minutes versus being there for 14 hours, why would I choose to be there for 14 hours? And the only reason I can explain, and I can still hear the words coming out of our friend Elliot Berlin's mouth, is to honor the desires of their client, right?
Oh my gosh, that just gave me chills because I think everyone wants that type of provider, right? Every woman goes into the hospital hoping that they have a provider that's going to honor what they want. And I think so many of us go into the hospital and that's not what we get.
And I think your audience and my audience know this. And I'm just hoping that we reach, by diffusion, by whatever method it gets out there, so that people, families, women start asking questions of their obstetrician before they're even pregnant
Yeah.
or very early in your pregnancy. Don't wait until you're 37 weeks to find out your baby's breech, or don't wait until you are 36 weeks with twins and they're suddenly telling you you've got to be induced next week.
Hmm.
You need to know ahead of time how your doctor feels about breech birth and about going past 40 weeks and about What happens if I break my bag of waters and I'm not in labor yet? Ask the questions. Ask, if I'm in labor, what are the odds that you're going to be the one catching my baby? I
Yeah.
almost said delivering. So don't want to do that. The woman delivers the baby, and obviously the doctors or the nurses or the midwives catch the baby or the husband. But you want to know these ahead of time. And if they don't have these skills, and you're one of these 6% of women that has a breech baby somehow in your belly, you're screwed.
Yeah.
And you're going to be coerced subtly or overtly into believing that it's unsafe and dangerous and you wouldn't want to harm your baby, would you? And all the language that's used to get women to funnel them down the path that the doctor wants them to do, which is to schedule that C-section at 7:30 in the morning on a weekday.
Mm.
Um, and that's not better for mom. It's not better for baby, and the data supports that. It's not better for mom's future babies. And yet that's what they do. I talk about breech all the time, and they'll label a breech mom to be high risk. And the solution for that is to do a C-section on her, which they will not label high risk. Yet if you ask yourself statistically, which is higher risk, delivering a breech baby vaginally or having a C-section for your breech baby and wanting a second or a third baby, the C-section is higher risk,
Every time.
statistically speaking, actual risk numbers. But you'll never be told that.
I
This
think
gets
a
into
lot of I think a lot of obstetricians actually believe that too. I think they genuinely believe that breech birth is more dangerous than a major abdominal surgery.
Well, in their hands, it probably is. I mean, I have to say that. But yes, they're indoctrinated to believe that.
Yeah.
But this is where this is the thing we can digress for a second and just talk a little bit about what high risk means. And I like to do this because this is a term that's thrown out there all the time. It's higher risk to do that, or this is high risk. What does it mean? Doesn't mean anything because high risk is not a number. High risk is something that makes the doctor or your system uncomfortable, and therefore they project it upon you. And I know that because of one example I just gave you, which was the breech vaginal delivery versus a C-section for breech. But even things like, what's the risk of a breech baby having a interpartum death or a neonatal death? And if you look at the Royal College of OBGYN has the best data on that because it's in their guidelines. It's from the 2017 Green Top guidelines if people want to look it up. And they say that the risk of having a neonatal death with a vaginal breech delivery is 2 per 1,000, which is 1 in 500, which is a 99.8% chance of not happening. The risk of a neonatal death with a head down baby, which nobody would say we should section all head down babies. I mean, there were people that said that, but I don't think they have any credence, is 1 in 1,000. So it's twice as risky as a head down delivery. And if you just told a woman that, that might be nervous for her. And it's 4 times riskier than if you do a C-section for that breech baby. But it's still 99.8 versus 99.9 versus 99.95% chance of it not happening. And if you told a woman honestly, in skilled hands, what's the difference between 99.8 and 99.9? Not a lot. It's 1 in 1,000. So if you section all breeches, 1,000 breeches, you're going to be doing it to save 1 baby.
Hmm.
That's crazy. Because then you put 990, well, you put 1,000 women at risk for their next pregnancy. And I say this all the time, HeHe. One of the things that I've learned when I was interviewing patients who came in for breech consults, when I was still practicing and doing the home birth world, I would often meet these people at 37, 38, 39 weeks for the first time. And a lot of them were seeing OBs, and they were sent to me by their doulas. They weren't sent to me by their OBs. They were sent to me by their doulas. And I would ask them at the interview, I would say to them, did the doctor who's recommending a C-section for your first baby, for this breech baby, did that doctor ever ask you whether you want more children? And the answer, you're shaking your head, the answer is no. Because what happens downstream doesn't matter to them. How's that baby doing a year from now, 5 years from now? How did that mom do postpartum? Did she recover fine? Did she have trauma? Did she have postpartum depression or breastfeeding problems? How did she do in a subsequent pregnancy? Did she have a ruptured uterus? Did she have a placenta accreta? They don't care. Nobody's looking, but we do. And this is stuff all I learned I learned this from midwives. I had to unwind a lot of the things that I learned as resident and that I did in the first 10 or 15 years of my practice that I look upon now and feel like how silly that was. Some of the silly things I did. For instance, for doing a vaginal delivery, the woman would be on her back in stirrups. I would wash her bottom off with betadine.
Mm.
I would put blue sterile drapes over her legs. I'd be dressed in the full hazmat outfit to catch a baby, and then the baby would come out. Probably I cut a episiotomy. The baby would come out. I'd fumble with the clamps because I couldn't clamp the cord fast enough. I'd show you this baby that you just delivered, and then I'd walk it over and set it down on the other side of the room in the warmer. And I did this for years until midwives, again, this is a composite memory, but midwives started asking me, Stu, why are you doing that? And it's like, I don't know. Why am I doing that? And I'm doing it because of habit and not thinking. A lot of what stuff that's done in the obstetric ward now these days is not done because of thinking, or it's done because it's always been done that way. Why does a woman with twins have to deliver? She can't deliver in the LDR. She has to go to the operating room to deliver. Why? Because she might need emergency surgery. Well, somebody in the labor room might need emergency surgery too. You figure out a way to get them down the hall. And why do we have to have 10 or 12 or 14 different strangers in the room? Because we have to have two peds crews, an anesthesiologist, scrub nurse, a circulating nurse, a couple medical students, janitor, the bus driver. I mean, you've seen the scene in the Monty Python's skit where they have 50 people in the room, and the woman says, Doctor, I think the baby's coming. What should I do? And John Cleese says, nothing, dear, you're not qualified. Right. So, I mean, that they still do those things. By the way, these guys were geniuses because they wrote this stuff in the 70s, long before any of us realized how stupid it was.
Yeah.
Uh,
It's really, I feel so lucky that I'm in this world and I get to do this work every day. I've seen vaginal twins births. I've seen vaginal breech births. I've seen home birth of both of those. I feel super lucky because I think that I would probably fall in that same category of being scared. When I started to interview home birth midwives, it was incredibly important to me that we hired somebody that was comfortable with breech birth, that was trained and comfortable with breech birth at home, because I knew that I had no control over that. I can encourage my baby to get in optimal position and
yeah, you
down,
can. Yeah,
but and there are things that you can do if you find that you have a breech baby, but at the end of the day, your child determines that, right? We're only going to be able to encourage a baby so much. And I did not want to be forced to have a hospital birth simply because my child was not head down. And so I didn't actually even interview anyone who didn't have breech training. If they didn't explicitly say it on their website, I didn't even put them on my short list of midwives to interview. I luckily have the training thanks to you and Nathan and Rixa, and I'll have my husband go through some training as well so that we're all kind of on the same page. But I knew that I did not want to go be in the hands of an OBGYN who touted themselves as being, breech trained or twin trained or fully trained, the expert of birth, yet they're not fully trained because they don't have the skills to attend every single birth. There is a subset of births that they simply won't even talk about.
and because a lot of women don't have the option that you have, or the wisdom or the knowledge, I listened to your podcast with Elliot.
Yeah.
I was just wanting to see how you do it with your podcast, and he said something very smart. He said, "Listen, if by 32 weeks you want to know if your baby's breech, you want to start to do things then, not because being breech is pathologic, but because of the lack of choices." And if you're in a community that has nobody to support you and you don't have the ability to travel or to relocate, then you want to do everything you can to help that baby turn to head down so you don't have to deal with all the crap that goes on when you have a breech baby at term. And you don't want to have to put yourself through an external cephalic version just because there's no option for you otherwise. And with twins, they're parallel, they're very similar because if we talk about twins, if we get back to twins, I mean, we'll probably cross over many times, but twins do carry certain problems that are more prevalent than singletons,
Okay.
and we shouldn't ignore them. But twin birth is not something to be feared. It's to be respected, like all birth, it's to be respected because the things can go awry and you need to be vigilant. But when they don't, and when you make it to term with twins without any real significant problems, and we'll talk about the fake problems that you'll hear about from your maternal fetal medicine specialist, but if you make it to term, then it's just a vaginal delivery followed quickly by another vaginal delivery. Right. It really is. And in the hospital, they'll do it very quickly because after twin A comes out, they'll immediately go up and rupture the membranes of twin B. In the home, we were a little more patient than that, although I did learn from my own experience that waiting too long increases your risk of a postpartum hemorrhage,
Okay.
which is also one of those factors that's higher in twins. So things that are more common in twins antepartum, certainly the number one risk factor for twins is preterm labor or premature rupture of the membranes. And that's not something you can necessarily do anything about. Now, there's been a lot of studies and a lot of proposals about all the things that you can do to prevent prematurity in twins, things like pelvic rest and progesterone and pessaries or cerclages or decreasing your activity or not picking up your 2-year-old toddler. None of those things, by the way, have been proven to be effective.
Hmm.
So unless you have an incidence of preterm labor or the rare situation of an incompetent cervix, that's a term Bliss and I don't like. Yeah, because it sounds bad, but your cervix gives out early. And the difference between that and preterm labor is that a cervix that gives out early does so painlessly. So if you have contractions and your cervix dilates, that's not an incompetent cervix. An incompetent cervix is one where you're having no symptoms, suddenly you're having increased vaginal discharge or something like that. You go in and your cervix is 4 centimeters dilated, you had no clue. And you're only 22 weeks pregnant or something like that. But barring that history, then there's really nothing you can really do to prevent this most common thing. You don't have to be at pelvic rest. You can pick up your 2-year-old. You just have to do it, ergonomically effectively. Try not to use your lower back, try to bend your knees, pick your baby up that way and stuff like that. Another one that's really important that happens only in mono-di twins is something called twin-twin transfusion syndrome. And that is a serious thing that can happen. It's random. It's about 15% of mono-di twins. And in my experience, mono-di twins make up about 20% of twins. Maybe less now because of IVF and stuff. I don't know. So we're talking about 15% of 20%. We're talking about a small number of twins will develop TTTS, which is quite serious. And if it becomes severe enough, then there is one of the miracles of medicine. I tend to rag on the medical model a lot, but one of the things I'm really in awe of is the fetal surgery that they can do with the laser surgery, where they can go in and find the communicating vessels and laser them, and then they can stop the process, where if they weren't able to do that in the era before that, more than 50% of twins in mono-di twins with TTTS died, did not make it, did not live. Now it's increased the odds greatly. So that's a great thing that's happened in medicine. And then there's things like cholestasis and preeclampsia and growth restriction. Another topic where we could spend a whole hour talking about the redefinition of growth restriction and how kind of foolish that is. Maybe I'll take a minute if you don't mind.
Absolutely. Go for it.
Okay. All right. Up until about 2020, the definition of growth restriction, simple definition, was babies less than the 3rd percentile. Okay. Which would be 2 standard deviations below the mean. Technically, that's 97.5%. All right. So in 2020, for whatever reason, the Society for Maternal Fetal Medicine redefined growth restriction as less than the 10th percentile, which I find to be, geez, what's a good word for that? Nefarious at best. Because what that would imply is that they're saying that 10% of babies born in the United States are growth restricted. Because by definition, if you're in the 10th percent, lower 10th percentile, 10% of babies have to be in that thing. And so that's rather suspicious to me. But what's also suspicious is that obviously that created a huge increase in the number of women who are labeled as growth restriction, which increased the business model for maternal fetal medicine doctors to make far more ultrasounds, more color flow Doppler, more visits. It generates a huge amount of revenue by labeling that. So in our study, we had 100 sets of twins, which means we had 200 twins. And we only had one baby that I would label as growth restricted.
Wow.
So that's half of 1%, not 10%. We should have had 20, according to. And that brings me to one other thing about twins, is that for any of you that have twins out there and you're going to an MFM and they're doing interval growth scans on you, sometimes they're indicated, obviously, and there is some standards that do apply that make sense, but you have the right to say no if you're feeling that babies are doing great. But if you go in and they are measuring your twins, ask them to measure your twins on a twin growth curve. Because the growth curve that's built into your ultrasound machine, your doctor's ultrasound machine, is generally by a guy named Hadlock, and it's designed for singletons. And if you look at a true growth curve for twins, by about 27 weeks, twins and singletons grow about the same rate.
Okay.
And then after 27 weeks, twins fall off. So that by 36 to 37 weeks, a twin that's on the 50th percentile for twins will be less than the 10th percentile for singletons. And guess what they're labeled?
Fetal growth restriction.
Correct. And then they'll be followed. They'll have extra testing. They'll have exposure to extra ultrasound that they probably don't need. They'll have extra fear and anxiety, and they'll be told they need to be induced. And this is what happens. So finding somebody that you can trust is not easy anymore in medicine. Simple test is if they're telling you to still get the COVID shot while you're pregnant, you can run away from that one. But that makes it easy. That's a huge red flag, as is potentially getting the DTaP and the flu and the RSV vaccine too. But people, it's another podcast for another time. So growth restriction if true growth restriction is more common in twins, but it's not more common because of the graph. You've got to work outside of the graph, because the graph is going to find it all the time. And twins by nature are smaller. The average birth weight of a twin is probably a pound less than the average birth weight of a singleton.
Wow.
At term. So you have to be careful. So those are the things that make twins a little more risky, and you need somebody who's capable and competent to watch you, to be vigilant. But if you make it to 35 weeks, which I consider to be term for twins, then there's really very little that you have to worry about. Yet you will be told the opposite. You'll be told that if you have different types of, one of the things we haven't talked about yet is chorionicity. And chorionicity in twins is very important. And it can be easily determined early on by just looking at the dividing membrane. And there's thickness and signs that you can look for that tell you whether the twins are di-di, which means they're fraternal, and mono-di, which means that they're identical. And then the rare case of mono-mono twins. Mono-mono twins is very rare. It's about 1 in every 300 sets of twins. So you can do the math and figure it out. That's a very small number of mono-mono twins. And if we want to talk a little bit about that today, we can. But let's just talk about mono-di and di-di, because those are the two most common. Again, in our paper, we found that di-di twins was about 80% of twins. Just an interesting anecdote is that about 1 out of every 7 sets of di-di twins is reportedly identical. But they're not at risk for TTS or anything else because they divided before they implanted. So they have 2 separate placentas. And by the way, di twins can have placentas that fuse together. That doesn't put them at any risk. They're just like taking two hamburger patties and squishing them together. They don't communicate. They're just together, so they may come out together. If you see that it looks like one placenta, but two umbilical cord insertions, that can still be di. So that's not about that. It's not about having two separate placentas. But that's about 80%, and about 20% are monodi, and they share a placenta. And monodi pregnancies and IVF pregnancies, along with monodi pregnancies, are often more common and will have funny cord insertions. Again, not something you can do anything about. Maternal fetal medicine doctors will spend 5 minutes with the color flow Doppler looking at the cord insertion and looking for velamentous cord insertion. And yeah, it's important if it covers the cervical os, something called vasa previa. But otherwise, if it's in there, there's nothing you can do about it except make the mother worry the whole pregnancy. So we sometimes look for things because we have the technology to do it, but we don't have any remedy for it.
Except anxiety, right? It just gives that woman extra anxiety. But then you can also see how it does push her down that path of, well, you have this, so now we need to induce. And because you're twins, that's extra high risk. So now we certainly should induce. And you're just increasing that anxiety. You're increasing that risk that she has unneeded interventions. And it is a conveyor belt.
Yeah, there's nothing a woman wants more, you can testify to this, than her baby to come out safely.
Totally.
Right. And there's no better way to manipulate anybody than by using fear.
Every time.
So if you use fear-based tactics, fear-based language, and you use the baby as you wouldn't want this to happen to your baby, would you? That sort of language, you can get pretty much any pregnant woman to do anything. So that's why, again, it's very important to pick your OBGYN early on or your midwife early on so that you feel really comfortable with them.
Yeah.
And if they look you in the eye, if they're not sitting there typing into their EMR, if they're not 1 foot out the door, if they give you more than 10 minutes of time, and you feel better. And this was from the Down to Birth ladies. I love them.
Yeah, me too.
They said that when you go to the OB, you generally feel a little bit nervous. You should come out of the doctor's office feeling great. If you come out of the doctor's office feeling worse than you felt when you went in, that should be a red flag for you that maybe this isn't the right setting for you, because pregnancy is not a disease. It's a normal function of a woman's body. It's a superpower, as everybody talks about. It's amazing. And it does it right most of the time. And this is one of those primitive things in your body does, which you don't have to think about. Like breathing or digestion. I mean, you and I are sitting here talking, neither one of us is thinking about digesting our food or remembering to take a breath. Body just does that. So you don't need medical care for that. What you need medical care for is if you have pneumonia or if you have colitis or an ulcer or something, then you maybe need medical care, but certainly not for breathing or digestion, nor for normal pregnancy, which is why the midwifery model is the way to go. We just don't have enough midwives in this country, and we have such a military, that's a Freudian slip,
Yeah.
a medical cartel that controls the language, it controls the media, it controls the hospitals, it controls the insurance companies.
The
And
data.
the data, oh yeah. Well, how do you know what's honest science anymore? If Rix and I put it out, it's honest. That you have it. No. I'm just saying that yeah, it's all corrupted. So it's very hard to know, which is why your podcast is so valuable and so many people listen. And I hope that people will share it with their friends who are pregnant without being too pushy.
Yeah.
You can only lead people to water. You can't make them drink. I mean, I talk about my family and the COVID vaccine, and they trust my judgment on a lot of things. And when they're sick, they'll call me. But when I told them not to get the COVID vaccine, they all did anyway. Now, my kids did it because either they needed to keep their job, which is the coercion of the worst type, or because my daughter, who I love dearly, wanted to make sure she could get into music festivals.
Oh.
Which, by the way, is
Hey,
also
that's valid.
coercion.
Yeah. Yeah.
Right. You can't come to well, they canceled Coachella the first year, but you can't come here, you can't go to this venue. I remember going to, when finally, I'm a big hockey fan. I was a Kings season ticket holder. And when they opened up the Kings again, you were supposed to wear a mask when you
Mm.
went to the games. But if you're eating a hot dog, you can take it off. So just like being on an airplane, you got to wear a mask. Oh, but if you want to eat your peanuts, you eat them one at a time and very slowly. And you can, I mean, it's just, if people just take a step back. And that brings me to another thing that I have to do with twins, which is a general rule that I have, which is my exact number rule. Maybe you've heard of it, but the idea that twins should be delivered by such and such number of weeks,
Right.
and that you should only have this many hours of ruptured membranes, or if you're over 35, this is a big issue, or you get 1 minute of delayed cord clamping. Where do these numbers come from? And they're all made up. They're not scientific. And the reason I bring that up now is because I was thinking of COVID, and the worst one of those, the best example is the 6 feet apart thing.
Which has now come out, and they were like, yeah, we did actually make that up.
We made it up. Well, they make all the other numbers are made up too. Age 35 is not you're not fine at 34 years old and 11 months, and suddenly not fine at 35. Are there some things that have a slightly higher chance of happening the older you get? Yeah.
Sure.
But a higher chance does not mean high risk. It does to the medicalized model, and it does to the people, as you said, that they truly believe it. They're indoctrinated to believe this. And if they never see anything else, they don't know. Most of my colleagues have never seen vaginal delivery of twins. They've never seen it. So how would they know that it's normal?
Or how would they know it's dangerous if you've never seen it?
Well, because they're told. It's passed down. It's like folklore. It's like sitting around the campfire and telling horror stories.
That's exactly
That,
what it is. Folklore.
yeah. Because if you take a dive into the literature, and again, maybe literature's always been corrupted, but I don't know that it was as corrupted 20, 10, 15, 20 years ago as it is now. But there's so many papers out there that support vaginal delivery of twins. And even Mary Hanna, who wrote the term breech trial, which said that you should do C-sections, she did a twin study. And then the twin study, they found they only looked at vertex first twins. They didn't do breeches in their study. And they found that beyond 32 weeks, there's absolutely zero advantage with a head down first twin of doing a C-section over vaginal delivery. Yet if you come in at 32 weeks in labor, they're going to say, "Oh, preemie twins. Oh my God, we have to do a C-section," and you don't, but they do. And the same thing goes with breech. There are authors that we quote in our paper. Blickstein's one of them. Avaram's another in our paper that looked at breech first twins over 1,500 grams. 1,500 grams is about 32 weeks. It's 3 pounds, 5 ounces. That they found that in breech first twins over 1,500 grams, there was no benefit to doing a cesarean section. And fairly large studies. And this was 20 years ago, when the skills, 25 years ago actually, when the skills of breech were still available.
Mm.
Now it's probably much more dangerous because people don't know what they're doing. So the woman who's pregnant with twins needs to do her homework. She needs to seek out people that are comfortable with reaching inside and turning a baby around or pulling a baby out if you have to, and knowing what to do and knowing when not to do it. Those sorts of things. Same thing with singleton breeches.
Yeah. Okay, so I have a question about what we see in other parts of the world. So outside of the US, are vaginal twin births kind of the norm for twins?
Oh, I don't think so. I think it's disappearing most places,
Wow.
just like breech.
Wow.
I mean, when you have countries like England, which everybody thought had a great birthing system because they had the National Health Service and they had midwives, and you could have a home birth with the National Health Service. You know about the British system?
Yeah, Australia
Yeah.
is very similar.
Yeah. Well, their data from last year showed that they have a 39% C-section rate in England. Yeah. This is the model by which people here want us to practice. And I'm surprised we still only have a 33% section rate. But by the way, that varies greatly depending on the institution you go to. So you need to check out your community hospitals, your teaching hospitals. You may have to drive to the next city or state to find a place that's going to support you. But if you want more children, then it's really important to have that vaginal delivery. And if you're a multiparous woman, and the difference between your audience knows the difference between multips and primips, I'm sure. Our paper was not big enough, numerically wise, to reach statistical significance, but certainly showed trends. And we had 46 out of 47 multips deliver vaginally,
Right.
which was 97.9%. Now, most of those women would have had C-sections in the medicalized birth model. We had a 68.2% success rate with primips at home. And we had 69 women that went into labor. 31 were transferred antepartum for the reasons that I discussed earlier, preterm labor, those sorts of things. Of the 69 that went into labor, 61 delivered at home, and 8 were transferred to the hospital. And of the 8, 2 of them ended up having vaginal deliveries because I was fortunate enough in LA to have Dr. Chavira and Dr. Crane, who were willing to take them and give these women the epidural and the Pitocin that we would do if they were a singleton, but do it. So we had 6 C-sections out of 69 women, which was an 8.7% C-section rate. And I'm not saying it's reproducible in any given practice, but it certainly is better than the 75% C-section rate that apparently is, according to the CDC, is what we have right now for twins.
But it also opens up the question of, is it replicable? Can we do this? If we can't, how come? Are there certain things that we're doing along the way that prevent us from being able to replicate it? And how might we be able to change those things?
Well, one of them would be legislation.
Totally.
Right now, the people that know these skills are regulated out from doing them, and that would be the home birth midwives. So in many states, now there are states here in the Southwest that do allow it. Nevada, Arizona, I know, Utah, I think you can do breeches and twins at home. Midwives can. Some of them are unlicensed, which is fine. Licensing, by the way, does not make someone better. Being board certified does not make someone a better doctor. Being a fellow of the American College of OBGYN does not make someone a better doctor. How do I know that? Because some of the worst doctors in the world are board certified fellows of the American College of OBGYN. And because I was board certified for more than 20 years. And when I left the hospital system, actually before that, I gave up my board certification. It wasn't serving me for any purpose. They didn't want me anymore anyway. And did I suddenly, on the day that I wasn't board certified anymore, become a worse physician than I was the day before?
Lose all your skills.
Yeah. So again, by the way, no one in my entire career ever came to my office to interview me for a first-time visit and said, by the way, are you board certified? Because it doesn't mean anything. It's a club. It's like, do you belong to Oak Ridge Country Club? No, I didn't. Never belonged to any country club. You know, I'm kind of like, who was it? Was it Groucho Marx or Will Rogers that said I wouldn't want to be a member of any club that would have me? So I don't mean that, and I'm just making light of it. But you don't have to be it. So we need to change the legislation, let midwives do what they want, and let women choose how and where and with who they can give birth. That's one thing. We need to bring back training. If we don't bring back training, and 98% of births are still in the hospital in our country, a little bit more than that, and we don't bring back breech and twin delivery skills training, and some of the hospitals may have midwives in them, but the midwives will be banned from doing those things anyway. They'll say it's outside their scope of practice. Even though, as Rixa will tell you and I will tell you, when we hold a seminar, almost all the people that are attending it are either doulas or midwives. Every now and then I'll get a family practice doctor, and they may come not because they're actually planning to do it, but because they want to know how to do it. Because they know at some point in their career, some woman is going to walk in. Again, we're back to breeches, but they're going to walk in with the butt sticking out of the vagina, and they're not going to know what to do. And so they'll push the baby back up and they'll do a C-section on the mom when they could have had the baby out in about 15 seconds. If it was in trouble, or if it wasn't in trouble, just get her off the bed, put her on all fours and let her push it out. But they don't know that. And they don't want to know that. And the system, again, financially doesn't want them to learn it because there's less revenue generated for the system if you have a vaginal breech birth or a vaginal twin birth.
Mm.
And I would say that the other thing that they could do to encourage this would be how they finance birth. Right now, whether it's in some socialized countries like Canada or England, medicine, the government pays, but in our country, it's insurance companies that pay, or it could be Medicare or Medicaid. They pay more for a cesarean section than they pay for a vaginal delivery, which means they think it's more valuable because that's the law of economics. If something more, you get what whatever something's worth is what people will pay for it. So if they were to change the pricing and say, we're going to give you half as much for a cesarean as we were last week, and we're going to give you 50% more for a vaginal delivery. So we're going to make vaginal delivery worth more than a cesarean for the doctor and the hospital. You'd suddenly find that breech birth would be back in residency training programs, and VBAC would be supported everywhere. You would.
All right, when we got pregnant, you know that one of the things I was most intentional about was building my baby registry. Not only did I want to only get things that we were absolutely going to use, but I wanted to make an investment into pieces that were going to really stick with our family for years to come and through multiple children. And to be honest, I learned about Lalo throughout this process, and they have a couple of staple pieces that I had to have. First and foremost, the minute I saw their hook on high chair, I knew that I had to have it. It's the definition of easy. And for a family that travels so much, Mr. HeHe and I are like on the go all the time, international, across the US, down to see my parents in the South. I knew that I had to have a high chair that could travel with us, that was light, that was compact, that could really serve our family on the go. And this is the one. It attaches right to your table, so baby gets to eat with you, not off to the side. And what I love the most is that it wipes clean in seconds. No crumbs hiding in weird crevices, no fabric to wrestle with. It's sleek, it's functional, and it actually blends in with your kitchen if this is a piece that you want to use as your full-time high chair. The other thing that I found absolutely drool worthy was their play kit, and it's the cutest little play table and chair set, and it's like little kitty size, and I just loved it so much. I had to have it. So of course we got it for our playroom. And honestly, it's one of the things that every time I look into that playroom, I just imagine little baby Saggy sitting there coloring or playing with trucks, or I don't even know what they'll do at that play table, but I'm so excited to see what kind of magic they make happen. This is also a place where you can put it in your kitchen. Maybe this is a place where in your family snacks happen or crafts happen or just general chaos. If you're anything like me and you really, really desire for your children's gear to be minimalist and look beautiful in your home, but also have materials that are durable so that it lasts and that it grows with your child, this is something you absolutely have to have, because this is not a table and chair set that you're going to toss after one season of toddlerhood. I love Lalo so much because they really do get it. They design baby gear that supports development, family connection, and it's actually aesthetic. So if you're building your registry now, or you're just ready to upgrade to some really high quality baby gear, go to meetlalo.com and use code HeHe. That's HeHe. Again, that's meetlalo, LALO.com, and use code HeHe, HeHe, and get your hands on baby gear that doesn't just work, but it works beautifully. Now, what do you say about, and I'm playing a little bit of devil's advocate here. What do you say about offsetting the cost that it takes to have a C-section, because you have more staff, you need to run an OR, things like that, in comparison to the cost that it takes to have a vaginal birth?
I would argue that the typical labor, what, 12 hours, 14 hours, whatever it is more labor intensive. You need more nursing. You use a lot of supplies. Anesthesia is there anyway, because 80% of women in our country are getting epidurals anyway. I don't know that it's that much more costly to do a cesarean section. You're basically you're occupying a room for 45 minutes as opposed to 14 hours.
Huh.
And a hospital system runs on turnover. So if they can get that C-section done and get that baby to the nursery, or maybe even have the baby have a little bit of a problem because it came out by cesarean, and have the baby observed in the NICU where they can really ring up the bill. And I know people who know me know I sound like this. For people hearing me for the first time, it may sound snarky what I'm saying, but it's absolutely true.
It is. Yeah, it's the truth.
Hospitals are businesses.
Mm-hmm.
The other thing you could do with a hospital is you could pay them more per delivery depending on their C-section rate in the hospital. Now, I don't want to go as so far as to what insurance companies did in the late 80s and 90s with VBAC, is that they mandated they wouldn't pay for a cesarean unless the woman tried a VBAC. They mandated that women try VBACs for a short period of time. This was a time when they were using Cytotec to induce them, and then we had a lot of uterine ruptures. And again, another short-sighted medical decision making. I don't want to coerce hospitals into cutting corners so that they hurt care. But you could say to a hospital, if your C-section rate's under 30%, you get this much for a vaginal delivery, this much for a C-section. If it's over 30%, you get this much for a vaginal delivery, this much for a C-section. That way you give them incentives to do things, because they're not going to do it voluntarily.
Right.
They're not going to do it because it's better for the woman. It's basic economics. We all learned this, hopefully, that if you want more of something, you subsidize it. If you want less of something, you tax it. So these are very simple things. Obviously, we can't get rid of the hospital. We need them. And many twins need to be born in a hospital.
Okay.
We can get back to twins if we want. This is what happens when I talk. I wander off.
No, this is helpful. I've long been a proponent, and this is something I came up with many years ago, is I actually think that each hospital should have a like acceptable C-section rate based on where they are and the population that they serve, mainly the population that they serve. And for every C-section that you do above that rate, you're penalized. And as long as you stay under that rate, then you get things like government funding and you do get an appropriate reimbursement rate. But if you go above your C-section rate, you either have to go before a review board, and I'm talking for every single C-section that is above that rate, you have to justify that it was truly medically necessary, or you get penalized, and then there are other additional penalties like your funding gets pulled and your reimbursement rate goes down. I just think I agree with you in terms of like none of this is going to happen voluntarily. There has to be repercussions, and I am not a punitive person at all. I'm the opposite. I am always saying, like, there's no need to punish this person. I'm sure they learned the lesson. Let's just have a discussion about it. We can see what went wrong. We can see how we can do better in the future. But I don't think that approach would work in such a system like the hospital system, because there are a lot of things that are just, they're not designed to support women.
Yeah, in the system as it's designed now, what you just said is very logical, right? And wouldn't be hard to do.
Right.
The problem is that the people who are going to make these decisions are the same people that got us in this mess.
Hmm.
And one of the things that I've talked about with people from my peripheral podium in Washington, I have very little say there, but I did get to give a talk not long ago. One of the things I said is that the people that have got us in this situation now, the American Medical Association, ACOG, the Society of Maternal Fetal Medicine, and of course the wonderful American Academy of Pediatrics, should have no place at the table when it comes to finding solutions.
Hmm.
They shouldn't, because clearly what they've done isn't working. I'll just recap for a second. If we go back 50 years, early 70s, right? We had a C-section rate of 5%. We had almost nobody got induced. 1 in 3 women had an ultrasound. Continuous fetal monitoring was essentially in its infancy. Friedman curve was just coming into play. All those things happened in the late 60s, early 70s. All right. We now have, and the rate of cerebral palsy, which is ultimately what you hope to prevent in intrapartum death, is the same now as it was back in the 70s. It's actually slightly worse. Now we have a 30% C-section rate, 33%. We have 30% induction rate. The induction rate, by the way, has tripled since 1990. Are our outcomes better? No. 75% of women now have at least 3 ultrasounds. When in 1970, one in 3 women had an ultrasound. Now, ultrasound is used excessively. Are our outcomes better? No. 80% of women are getting epidurals. Are our outcomes better? No. The rate of NICU admissions in the last 15 to 20 years has doubled, almost doubled. From somewhere in the 5% to almost 10%. Can you imagine almost 10% of babies are going to the NICU? And this is CDC data. So again, you can trust the source or not trust the source. So it's not about intentions. The intentions of the medical system have proven that it's about revenue generation. If it was about better outcomes, then all these people would have resigned in disgrace. But they keep coming up with new inventions, new things.
New interventions.
And one of the things that bothers me about all the sections being done is that we know if the section rate was 50 years ago was 5% and the outcomes are the same now, that some of the C-sections being done in 2025 have to be unnecessary.
Totally.
Question is, how many of them? Half of them? Should the C-section rate be 17%? Maybe. But if you agree with that, or even 20%, you're saying that 500 to 600,000 women every year in the United States are having unnecessary major abdominal surgery. If we had that many unnecessary knee surgeries or mastectomies or gallbladder surgeries, not only would people be upset, politicians would probably be upset, but insurance companies would be upset because they're paying for things that are unnecessary. Yet we probably have 500,000 or more unnecessary C-sections being done every year. Insurance companies say nothing. Why?
Why?
Is because women's health is a lower tiered? I think it is. I think it's been brushed off to the side. Do you know that when I was doing surgery, if I did an appendectomy, say I was doing a surgery for a ruptured cyst or an abscess or something, and I found the appendix was involved, and I did an appendectomy, I got paid less for the appendectomy than if I called a surgeon in to come do the appendectomy. He got paid more than I did. So I think that OBGYN has always sort of been the poor stepchild. But that's an incredible number. And then you ask yourself the same kind of question you ask yourself, why doesn't my doctor know breech? This is where cognitive dissonance comes in, because you'd ask a doctor who say he has a 35% C-section rate in his practice. And you say, the World Health Organization, not an organization that you or I probably have much regard for, but they say it should be 10 to 15%. So let's give it the benefit of the doubt and say 20%. You're doing almost double the rate of C-sections. How many of your C-sections are unnecessary? And he'll look you in the eye and he'll say, none. All my C-sections are necessary. So who's doing the unnecessary ones? And they'll say, well, that guy over at that other hospital, he's doing the unnecessary one. But what's the guy over at the other hospital saying? He's saying, you're doing the unnecessary ones. And so there's 500,000 unnecessary C-sections and nobody's doing them. Kind of, again, this is not complicated thinking. I'm not a genius for thinking this stuff up. It's intuitively obvious that we're not doing well. We're adding more stuff and putting more burdens on pregnant women, more testing and changing our guidelines. We're changing the blood sugar level that labels on a diabetic. We're changing, like I said earlier, we're changing the definition of growth restriction. We're finding more reasons to do more stuff, and our outcomes are not better. So that's why I said the people that have put this into place should have no place at the table. We have to figure out a way to save the hospitals though, because we do need them.
Yeah. We need them for certain situations, right? I'm the queen of saying like the only people in the hospital that are there and they are not sick is labor and delivery. And I'm not trying to make light that there's not a subset of the population that are truly high risk and genuinely do need the hospital and genuinely do need obstetrical care and MFM care. But for the most part, you shouldn't be birthing in the hospital as a low risk woman. You should be birthing at home under midwifery care. So I have a question. Oh no, go for it.
I was going to say, and the tendency is to sort of upcharge everything because if the hospital was only, say only 30% of women needed to be in the hospital, and that's a generous number. I think it's
Yeah, I think
less.
that's high.
But let's just say 30%. The hospital would close its door, it would close its OB units because they can't make enough money on 30% of the women. They need
Well, because
all
we
the
have too
normal.
many OBs, right? The point is that we've put too many OBs out into our population to actually serve the number of people who truly need obstetrical care, where really we should have been prioritizing and allocating funding for midwifery care. And now we have basically no midwives across our nation.
Yeah, and I do have sympathy for people that run hospitals because there's so much red tape,
Mm-hmm.
so much bureaucracy, so many regulations.
Yep.
Yeah, I mean, I just saw a post yesterday that said, what was it? Oh, to give an injection of something that wasn't a bad injection, just to give it, you had to be masked, you had to wear eye cover, mask, and gloves to give an injection. And it's like, why?
What are we doing here?
Right. I mean, there's so many whys. Why does a woman with twins have to deliver in the OR? Why does she have to have an epidural just in case? Why does she have to be on her back? Why can't she eat when she's in labor? Why are we inducing this? We can talk a little bit about timing of twin delivery. We can get back to that. But you got a question. I mean, sorry, it's your show.
No, no. I
Just
guess I wanted to, yeah, shift back to twins. You had mentioned mono die and then mono die. And then you had kind of slipped in there that some twins do need to be born in the hospital. I'd love for you to touch on that. Which type of twins do actually need to be born in the hospital? And are there certain type of twins that maybe do require a C-section and are not quote unquote safe to be vaginally birthed?
not necessarily based on type of twins.
Okay.
Just briefly for mono twins, which are two twins in the same amnion and the same chorion, we've all been taught standard teaching that there's a high risk of mortality for these twins. There's a high risk of cord entanglement, that they should all be hospitalized at 26 weeks and be on a monitor for 6 weeks, separated from their family and their dog and their husband, not necessarily in that order. But and then they should be delivered by cesarean section at 32 weeks. But the data doesn't support that. And they all say there's a high risk of twin-twin transfusion syndrome in mono twins. And to this day, I hear maternal fetal medicine doctors spouting that.
Hmm.
But the evidence, again, there's not a lot of data because mono twins are quite rare. There are several studies that look between 8 and 12 years at their data, and they had 29 cases or 32 cases. So they're too small to make conclusion, but they didn't have a single case of TTTS though. And if TTTS is 15% and you're talking about 60 sets of, you should have had at least 9 and you've had 0. Why is that? Because they think that the vessels are they're so intertwined and so communicating with each other that anytime one baby starts pumping blood to the other baby just pumps it back to the other baby. So as opposed to in mono di twins where that gradient is different. So everything that we learned about mono twins isn't necessarily so. So it's not necessarily the type of twins. It's if you have one twin that's not growing well, if you have a baby that baby A is in a transverse lie or the cord is presenting, the baby's laying and you look on an ultrasound or whatever, and all you see is a bunch of cord over the cervix. Or they have a placenta previa, obviously, same reasons that you recommend for singletons. Sometimes labors will stall out. Sometimes babies or twins can be extremely premature. And maybe they could deliver vaginally, but the hospital is a better place because the newborn intensive care unit can do wonders as well. I think the idea that NICU admissions have doubled in the last 15 years just tells me that I think that they're finding more reasons to put babies in the NICU because I just don't believe either. There's no good alternative to come from that because either we're doing worse and we're putting more babies in the NICU, or we're putting more babies in the NICU to make money. Neither one of those speaks well for the model by which they care for. So it's not necessarily the type of twins. We found that we didn't have mono twins in our study. We didn't have a single one, but we found that mono di twins and di twins had exactly the same outcomes once they made it to term.
Okay.
So the success rates were very high. For multips, we had about a 95% success rate with multips with twins. And with, oh, I said that already. I'm saying with Vertex twin A's, we had about a 95% success rate. With Breech twin A's, we had a 78.6% success rate. So just because a baby is breech is not an indication for a C-section. Yet women will be told that because doctors are scared and they don't know what to do. And so they project their fear onto the woman by telling them things that aren't true. Like maybe the cord will prolapse or this. Yeah, that might happen. Cord prolapse is more common in twins, generally with twin B, but it's usually not an emergency because you can just go up and if you have to, you can pull twin B out by something called a breech extraction. And you can do that. And that's a skill that anyone who's taking care of you with twins should have. So if you're listening to this podcast and you find out you have twins at 10, 11, 12 weeks, you should ask your doctor right then and there, do you do breech delivery? If they say no, then that is not a twin specialist and that doctor should not be taking care of you. Yet most OBs will not tell a woman that they should go look for somebody else. Partly because I think they believe what they're doing is the right thing. They believe that cesarean section is the safest mode. But again, they're not thinking of mom's next baby or mom's recovery or baby's microbiome or any of those things. They're just thinking, one of the slogans that I'm fairly famous for is they're only thinking about it for a live baby in the bassinet. And what happens to that baby and the mom down the road, the future babies, doesn't really matter to the system.
Now, do you think it's a red flag when a provider says, yes, I will deliver twins, but you have to let me perform an extraction?
Well, it's better than the alternative, but it shouldn't be that way, right? What's the alternative?
A C-section.
Right.
Hmm.
So if that doctor feels comfortable with it, then yeah, it's okay. Right. Will that doctor do a breech first twin though? That's a good question to ask. There's this whole famous thing about if you do a breech first twin, the second twin's head down, that the chins will get stuck on each other. It's called interlocking twins. And so they'll use that as a thing. But there are these large studies that I mentioned before about looking at the benefit of sectioning first twin breeches, and they didn't find any benefit. They didn't find any evidence of interlocking heads either.
Huh.
I did, however, it happened to me once.
Oh, wow. How did you resolve
I wrote a case report on it.
Hmm.
Because of my training and my knowledge of spatial relationships of what's going on, and because I took care of these twins their entire pregnancy, and I knew twin B, which had been breech for a long time, had flipped to twin A. I mean, had flipped to Vertex, and I knew his head was below the other one's head. I just thought that baby A would slip by baby B. When it didn't, I sort of knew immediately what was going on because, again, I had a continuity of care model that midwives have taught me. I had been the one doing her ultrasounds. I had been the one taking care of her the whole time. I sort of got to know the babies. It's kind of a nice thing that you have when you have that model. One of the best things that ever happened to me was sort of being forced out of the hospital and going into home birthing. And it was just like, that was great. But all I did was what I would do if a breech was having a problem. You just reduce station. You push the babies back up a little bit. The pelvis is shaped like this. You push it up a little bit. You got more room up here. Then you can push baby B out of the way and you can pull baby B out, and then baby B can come down head first and deliver.
Right.
And again, obviously I'm talking very calmly right now. Clearly probably my pulse was 160 and my blood pressure was probably 160 over 100. But it's something that you're trained to do. And if you're trained to do that and you're going to do twins vaginally, you need to know these things. I just don't understand why residency programs gave up on it. It wasn't because of the term breech trial. That term breech trial was just sort of the final nail in the coffin.
An easy way, an easy excuse to say, see, we should be stopping it.
Yeah, they wanted to stop it anyway in the 80s and the 90s, but they didn't have any data because there were some studies out that said vaginal delivery is fine. And there were studies that said that cesarean was better. So they didn't have that. But for whatever reason, and again, what reason could it possibly be? Laziness? No. Ignorance? No. Money? Yeah, it had to be. The history of medicine is fraught with this sort of stuff.
Totally.
Yeah.
Absolutely. And taking advantage of women. Okay, I want to dive into ECV. I know we only have limited amount of time left, but talk to us a little bit about an ECV because I've seen them be successful. I have seen them be unsuccessful. I have seen them cause people to go into labor. I have seen providers force people to do it in the OR. I've seen providers force you to get an epidural, and then once your ECV is over, you're then sent home, all sorts of just wacky and wild out things. What do we need to know about an ECV, and what is the success rate, and is it really worth it?
Well, if you don't have any other choice, then certainly it's something that's got some value.
Totally.
If the choice is ECV or C-section, however, there are things about an ECV that will help you predict whether it's going to be successful or not.
Okay.
They're not 100% predictive, but primaps are harder. Frank breaches are harder than complete breaches. Lower amounts of fluid makes it harder. An anterior placenta makes it harder.
Okay.
Fibroids can make it harder depending on where they are. So you can go into somebody, if somebody is a CrossFit trainer, Frank Breech, amniotic fluid index of 6, people that's like low, it's
Hello.
normal. It's on the low end of normal. Doesn't there's a lot of, the likelihood that that baby's going to turn around is very unlikely.
Okay.
If you have a woman having her 5th baby and the baby's complete breech and the baby has a fluid level of 15 or whatever, that baby's probably going to flip. But if you only have, if you don't, your only choice is a section, then it might be worth giving it a try. I don't like the idea of using an epidural. I think it's a mistake. I know that again, it generates more revenue because if they do it in the OR, if they do it with anesthesia standing by or an epidural in place and an IV in, stuff like that, those are all billable charges. I think that when I do it, when I would do versions, I'd like to see what the woman's face was doing. I'd like her to speak to me if I was pushing too hard. You can kind of tell if I'm hurting her. If she's got an epidural, I could push pretty hard and she's not going to be able to tell me I'm pushing too hard. And I may do something. I don't know that the data supports more abruptions or more things with an epidural. There are papers that suggest that it increases the success rate, but I'm very suspicious of those papers because I don't believe that that's true, just just intuitively. Now, maybe my suspicions aren't warranted here, but I just know that again, anything that generates more revenue, any paper that has a conflict of interest like that makes me always suspicious of it.
The two women
So,
that I know that have chosen to have an epidural, they both were successful. And the reason that they chose to have an epidural to do that, I do partly believe that it was presented to them as their only option. And their doctors did highly say, like, if you don't have an epidural, I'm not 100% going to do your ECV. So there was definitely some coercion there, but both of them did walk away saying that they felt like they were able to truly relax their belly muscles or their abdomen with the epidural because they were not subjected to the pain. And they both shared that, if I had been able to feel everything, I don't know that I would have been able to truly relax. So I think there's something to that, but I tend to lean just like you. I believe so heavily in patient consent that I believe if there's any sign of coercion, then now you have stripped consent from the conversation. You can't coerce someone and then also say, well, they wanted it and this is how it had to be. It's like, no, you actually didn't leave her any room to say no to that choice.
right. And I would leave the decision of whether to have one or not to the decisionally capable woman if she has a choice of a vaginal delivery. So again, I told you that the Royal College's numbers say that the risk is 1 in 500 from a vaginal delivery of having a neonatal death due to the breech presentation. Okay. What's the risk from aversion? I don't have a number in my head, but I personally, again, I'm not a woman and the way my brain works right now is if I had a choice of a vaginal breech delivery with a skilled provider, I prefer that, saying this is the way my baby's wants to come for whatever reason. There's an innate knowledge there. It knows what it's doing, or maybe it doesn't, but for whatever reason, it wants to be breech. It wants to be born breech. I've seen enough babies born breech to know that it's, in my mind, it's a variation of normal. There are people that say it's not, but it's 4 or 5% of all deliveries. So, I mean, something that's 1 in 20 isn't abnormal.
Right. I tend to
I
lean
mean,
that same way, that it's just a variation of normal. Smaller than cephalic babies, but normal nonetheless.
yeah, I mean, I always used to compare it to, the incidence of redheadedness in the world is 1.5%. And so you wouldn't say that someone's redheaded is abnormal. It's just the variation of normal.
Mm.
It's not quite a medical correlation, but it's a good example of the fact that vaginal breech delivery is a reasonable thing. Vaginal twin delivery is a very reasonable thing if you make it to term. And if twin A is in what we call a stable longitudinal lie, and there's no major anomalies with the baby, and mother is otherwise healthy and willing, has to have the right, like this is one of the most important things of all, is that the couple or the family has to have the right mental stuff. They have to believe that they can do it. They can't be laboring in fear. And they shouldn't have anybody else in the house or in the hospital, in the waiting room or anything like that, who's nervous as hell. Right. Because that energy is transmissible and you can feel it and you know. So the one other thing I want to talk about twins, because I know that we're going to wrap soon,
Yeah.
is when to deliver them.
Totally. Let's hit it.
Because this is what you'll be told in the standard medical model. And again, the evidence is very sketchy on this. If you have mono twins, you'll be told that they need to come out at 32 weeks. And if they come out at 32 weeks, where will they spend the next month?
The NICU.
In the NICU, all right? Is that better or worse? And from what I told you, you look at the data, and if mono twins make it past 20 weeks, the likelihood of having an adverse event is quite small.
Huh.
Almost all the adverse events happen in the first 20 weeks. All right, so the 32-week thing is very, very sketchy, but you'll be told that, and you'll be told that with great consternation. Because, oh my God, we have to monitor you for 6 weeks in the hospital. You have to be in the hospital, by the way, room charge every day, meal charge every day, fetal monitoring, continuous charge every day. Why couldn't she be at home? Because they're saying, well, suddenly the cords could become entangled and cut off the blood supply. Well, 100% of mono twins have cord entanglement. And almost none, essentially in the 2 papers, 0 of the demises were related to cord entanglement. Again, small numbers, small study. But so there's no evidence to support what they're doing. They're doing it because they've been taught to do it that way, and somebody who taught them to do it that way had a reason, but it wasn't so-called good evidence-based. Mono di twins, you'll be told, need to be delivered by 37 weeks. And di twins, you'll be told need to be delivered by 38 weeks. Neither one of those is true. And the reason they'll tell you that is because of the rising rate of stillbirth. And this is where they pull out, the infamous dead baby card, and they'll tell you that if your baby goes beyond 37 weeks or 38 weeks, that the stillbirth rate rises, which is a true statement, by the way.
It does.
The stillbirth rate rises in all babies beyond 35, 36 weeks. So the question is not that it rises, but the question is, of course, how much does it actually rise? And this is something that if you ask a physician who hasn't heard me or Rixa talk, you will find that they have no idea.
Or they'll say it doubles.
Yeah, they'll just make up a number, but they don't know what the underlying number is. In our paper, we let women go as far as 42 weeks. I'm telling you, they were pulling their hair out by then because they couldn't take being pregnant that long with 2 big babies in there like that. But our range was 35 weeks to 42 weeks with an average of 39 weeks and 0 days. So our average twin mom went farther than any hospital will generally let twin mom go. So let's talk about the numbers real briefly, right? At 36 to 37 weeks, in otherwise uncomplicated twins. And by that, I mean no growth restriction, no hypertensive disease or preeclampsia, and no diabetes. Okay. The risk of stillbirth is about 7 per 10,000. At 38 to 39 weeks, it's about 15 per 10,000. So it doubles, which is where you got your doubling thing. And if you go to 40 weeks, it's actually 46 per 10,000, which is almost 7-fold increase. Right now, that sounds horrible, 7-fold increase, but that's at 40 weeks. You could at least let the babies go to 38 or 39 weeks. But what is the actual risk of that thing happening? And the way to look at that is, well, what's the chance of it not happening? And at 36 to 37 weeks, if it's 7 per 10,000, that's a 99.93% chance it's not going to happen. And if it's 15 per 10,000 at 38 and 39 weeks, that's a 99.85% chance it's not going to happen. And at 40 weeks, it's a 99.54% chance it's not going to happen. So they may say it doubles or goes up 7-fold, but it's still less than 1 in 200, even going to 40 weeks. Now, there's no data beyond 40 weeks because nobody let twins go past that 40 weeks. So they don't have what it goes up to at 41 weeks or 42 weeks. But if we began testing our moms, I believe in the biophysical profile. I think it does give information. If you have a healthy biophysical profile, it's very unlikely you're going to have an adverse event within the next 2, 3, 4 days. So that makes good sense. And we didn't have any issues like that. But if you ask a woman, honestly, what's the difference between 99.54, 99.85, and 99.93? Most women are going to say not much. Yeah. Yet it's a 7-fold or 2-fold increase. So that's where using relative risk to skew your counseling is sort of unethical. It's not sort of, it is unethical. And that's where these standardized things come from. The protocols that you'd find if you were at Johns Hopkins or Harvard or Cedars. These are the protocols that they use, and they think that they're doing good. But they don't think there's any downside to messing with nature's design. Because again, all that matters to them is getting live babies in the bassinet. So they don't think that giving artificial Pitocin and bringing the babies out before they trigger mom to go into labor or however that works, placenta babies or whatever, that matters. That giving artificial Pitocin and then having a mom having to be on her back, sort of being monitored, or on her side being monitored the whole time because you got twins and we're inducing you. So that's a high risk situation, which now we've created. So therefore you have to be monitored, which then limits your ability to deal with your discomfort. So you ask for your epidural, which then disconnects you further. And anybody listening to you by now has heard the whole thing about the cascade of interventions. And therefore they end up with that 75% C-section. Well, a lot of those are just scheduled. So I don't know how many are failed labor, but a significant number are failed labor. And all for reasons and just that belong to the pregnant woman to make that decision for herself. And if my colleagues weren't so fearful of twins, if they knew more about twins, and the system wasn't so rigged against the doctors and the nurses and the hospital practitioners to have them so on edge and so worried about being sued. You know, doctors always believe they don't get sued for doing a C-section, but they don't care what happens downstream to that woman. And downstream, that woman could rupture her uterus in a subsequent pregnancy, and she and her baby could die. And no one's going to look back and say it was because of that C-section we did for her first baby for twins or breech. Yet I would. I mean, I've heard stories about this, and it bothers me greatly because everybody's pissed off at the midwife or the doctor for letting them have a VBAC and that sort of thing. And I look back and I say, well, why did she have the first C-section in the first place? And turns out she had it because she was breech or because of twins. She wasn't given an option for a vaginal delivery. And if she was, she would have had an 80 or 90% chance of success. And then the subsequent catastrophe wouldn't have happened. But they don't even know. The doctor who probably did her first C-section doesn't even know that she had this problem later on. Or certainly doesn't attribute it to that. And that's why, again, whenever you mess with Mother Nature, and I know that I'm talking to you, HeHe, and I know you know all this stuff, but there are going to be downstream consequences. You're going to change something. It may be insignificant, but it's something. And it may be something significant, but it may not appear for 5 or 10 years. We change their microbiome. We change their ability to navigate the vaginal canal and all the reflexes that are required. Bliss and I did a podcast on with two reflex people, and talked about how integrating the fetal reflexes is so important for newborns and for young babies to integrate the reflexes they needed to get out into making more, I don't know the terminology, but more advanced reflexes later on. And they even went so far, the thing that stuck in my head so much is that a lot of bedwetters, it'd be really interesting to look and see how they were born.
Hmm.
Because if you don't navigate labor, they said that that can lead to multiple things, ADHD, but bedwetting was the one that stuck in my head because, wow, that can be from the fact that the baby didn't get a chance to do what nature designed, which is for it to have to twist and turn and rotate and do, and have its conversation and communication with mom through that process. My colleagues in obstetrics do not think there's any value to that process.
Wow.
And that's counterintuitive to nature's design. Nature doesn't do things for it by accident.
Yeah, I believe that same thing. Oh my gosh, Dr. Stu, thank you so much for being here. Truly. This has been super insightful. I think it has been so empowering, and I think it has really unveiled a lot of answers that women so desperately want, but again, they feel gaslit or railroaded by the hospital system, and they are met with resistance from their providers regardless of whether it's warranted or not. It may be resistance that is drummed up by the fear of that provider and not really that woman deserves that. And I just want to thank you for coming on here and sharing your wisdom, being transparent, truly talking about the risk and the benefits, and really just putting the control back into our hands as the mom and the women and the birthing person. I just really appreciate you a lot.
Thanks, HeHe. Again, I'm including myself in the midwifery model because that's sort of what I do now. We understand we can't guarantee anybody they're going to have a good outcome.
Totally.
But we understand that nature's design is pretty damn good. And we understand that and accept uncertainty. And my colleagues in obstetrics fear birth. They don't trust nature and they want to control the uncertainty by putting in their own interventions, which then create a lot more chaos, but it's okay because it's their chaos that they like. So the last thing I would say is that to anybody listening who's thinking about being pregnant or is early pregnancy, we need to start to challenge the system in a very polite, cordial way where we go in for that first visit with our OB, and it may be in the person that's doing our pap smear for the last 10 years, or maybe you move to a new community and maybe or you have a Blue Cross card and it says you got to go to this practice or this HMO or whatever else. And initially you do that, but go with your first visit not as a patient. Go with your first visit as somebody who's interviewing you. Like you're going to look for cars.
Yep.
All right. You're not going to have the car dealer tell you which car to get and how much to put down and whatever. You're going to go and you may not buy a car that day. You may come back another time or go to a different dealer and look at a different brand of car, that sort of thing. You're not going to be an impulsive person. You're not going to feel you're trapped. Don't feel you're trapped. And ask the tough questions in a nice way to the doctor. If anything else, if it just makes them slightly uncomfortable, and if every woman comes in, and this is Rixa who said this, if every woman comes in and starts asking, why don't you do breech delivery? Why can't I go past 40 weeks or 41 weeks? Why do you only delay cord clamping 1 minute? Ask the questions and see how they look at you and see how they respond. Check out your community. If you move to a new community, you check out, where's the church? Where's the schools? How good are the schools? Where's the Costco? How much is gas? What are the taxes? You check these things out. Check out your local hospital that's in your community. Go in, speak to one of the nurses there, see how they treat you, see how they ask questions of them. Do this before you're even pregnant, or again, if you can, because plan for it.
Yeah.
Plan ahead because it's the most important thing you can do. And then find an advocate. It may be your partner, but that sometimes is a little much of a burden to put on partner. So you need to find a doula or what some people are calling patient advocates now, because the term doula is being hijacked now, just like the term midwife is being hijacked. I mean, these corporations want to now employ doulas and they want to, well, no, Think about it. If a hospital employs a doula, who does the doula work for?
The
So,
hospital.
right. Is a doula going to advise you against what the hospital is suggesting?
Not when their
No.
paycheck is coming from them.
So ask the questions and make this one of the most important events in your life because it is. You know, I watched you and your husband sitting in the car in your Instagram post, and it was just such a delight. One of my favorite things to do when I was used to be hospital birthing and even at home birthing was after the baby was out and the parents were oohing and eyeing over their baby, and I would be sitting in the corner in a chair with a chart. Charts were paper in those days, and I'd be writing out the orders.
Yeah.
And of course, I'd be writing some stupid orders too, like here, give her a shot to dry up her breast milk and all that stuff that we did. But I would just sit there and I would just watch.
Hmm.
And I think you said it earlier, we are very, very fortunate to work in this world. And I am so fortunate to have found the path that brought me joy. I don't think many of my obstetrical colleagues are happy.
Yeah.
And the reason I say that, and I've said it many times, is that happy people don't treat people poorly. They don't dismiss them. They don't coerce them. They don't embarrass them. They don't snap at them. And yet, there's too many stories about doctors who are probably insecure because I don't think they're well trained anymore. I think they're very smart book wise, but I don't think they're very well trained skill wise. And I think they make very, very nervous decisions. And so I'll quit there because I could go on and go off on another tangent. It's been an honor to be. I've known you for a really long time, and I followed you for a really long time, and I love your post. And I just have this image of you walking around the Breech conference with your little fluffy microphone. So,
Oh my gosh. I do love the energy at the Breach conference. It has been so pivotal in our practice as Tranquility by HeHe. And it's such a joy to be able to disseminate and disperse that education and that information and to be a conductor of that empowering information. And I really do love getting this information into people's hands so that they can make whatever decision is best for them. So thank you so much for being on the show. Thanks for being here. Thank you for sharing your wisdom. If people wanted to connect with you, continue to learn from you, anything, how can they do that?
well, I'm sure you'll put it in the show notes too. But everything is Birthing Instincts. So Instagram, it's at Birthing Instincts. The website is www.birthinginstincts.com. The podcast is birthinginstinctspodcast.com. On the website, I have the papers that I've written. They're open access. They're free. You can find them on the website. I make a lot of appearances on other shows. I hope to have a role. And again, if you follow me, you'll be able to pay attention to the things that are happening and try to make some changes in my lifetime. I'm not optimistic that will make big changes, but every change to one family sends ripples downstream because every family that has a beautiful birth, that story will then become the story of that family. And if you see your babies born at home, then I mean, if your children see their siblings born at home, then they're going to have less anxiety and less fear about all that. So yeah, Birthing Instincts is the way to go. And I tend to respond. I do a consult service, a meeting service where people can sign up for Zoom meetings with me for a fee, of course. But I do answer most emails that I get, pretty much all of them, even though sometimes my system generates an automated response. I will then also respond because I am retired from that now. I've spent a lot of time advocating and doing those sorts of things. And then teaching season starts up, and I do teach my 2-day Reteach Breech seminars. I hope to see some of you there. And you can find the schedule again on the website.
Nice. I love that. Thank you so much, Dr. Sue. And thanks to all of you for tuning in with us today. I hope that you found this episode really empowering. I hope you understand that twins are safe to be born at home and that you don't have to have a C-section. I hope you walked away with more information and understanding of your options around ECV and extraction and what does the research truly say about vaginal twin births versus scheduled cesarean births. I'll see you guys in the next episode. Be sure to follow Dr. Stu on social media, and you can find me at Tranquility by HeHe and the.birth.lounge. Until next time, head to your app store and download the Birth Lounge app for evidence-based childbirth education and data-driven postpartum support delivered straight to your phone. Bye. Thank you so much for tuning in today. I love hanging out with you, and it is an honor to be your go-to gal when it comes to preparing for your baby. If you've enjoyed today's episode, please leave a 5-star review and tell others why they should be listening to the Birth Lounge podcast too. You deserve to have a birth that you love with a provider that values your autonomy and respects informed consent without all the trauma that you so commonly hear about on social media. New episodes air every Wednesday and Friday. Hit that follow button so you never miss an episode. I'm HeHe, and this is the Birth Lounge Podcast.